Let's bypass the pleasantries and jump right into this high-yield clinical explainer. We're targeting that perfect 270 plus score today. Look, if you're aiming for the top percentiles, you absolutely cannot afford to have superficial knowledge of toxicology and acid-base derangements. You've got to understand the intricate, simultaneous mechanisms that literally trip up most clinicians. So let's just dive right in. All right, this simulation arc is going to march us through 3 intensive clinical modules. First up, salicylate toxicity and dual acid-base kinetics. Second, we'll tackle cellular respiration blockades. And third, hypoventilation syndromes and reversal hazards. Kicking things off with Module 1, salicylate toxicity and dual acid-base kinetics. We're going straight into the unique dual-phase acid-base derangement triggered by severe aspirin overdose. Now, salicylates create a seriously treacherous mixed derangement through 2 distinct pathophysiological hits. First off, they directly cross the blood-brain barrier and stimulate the medullary respiratory center. This drives hyperventilation, right? You're blowing off CO2, which causes an early primary respiratory alkalosis. But simultaneously, and this is key, down at the cellular level, salicylates halt ATP production. They uncouple oxidative phosphorylation. This forces the body straight into anaerobic metabolism. So lactate and keto acids begin to accumulate, and boom, you've got a massive primary high anion gap metabolic acidosis on your hands. Okay, whatever you do, do not let a near normal pH fool you here. Look at this blood gas profile, a pH of 7.43, a PaCO2 of 22, and bicarbonate sitting at 13. Now, a superficial glance might suggest a compensated primary disorder just because that pH is technically normal. But look closer. This profile completely masks heavily depressed PaCO2 and severely depleted serum bicarbonate. That screams concurrent, opposing primary disorders. You've absolutely got to calculate expected compensation. Applying Winter's formula, which, as a reminder, is 1.5 times the bicarbonate plus 8, to a bicarb of 13, gives us an expected PaCO2 of 27.5. But our patient's actual PaCO2 is 22. Because that actual number is significantly lower than the expected compensatory value, the expected compensation is way off. This literally mandates the diagnosis of a mixed high anion gap metabolic acidosis and a concurrent primary respiratory alkalosis. So the crucial point is, how do we actually manage this? Your strict treatment mandate requires systemic alkalinization. We administer intravenous sodium bicarbonate. Since salicylic acid is a weak acid, artificially raising the serum and urine pH converts the drug into its ionized lipophobic state. Basically, this alkalinizes the urine to trap the salicylate in its ionized form right within the renal tubules. This profoundly accelerates its excretion and, crucially, prevents it from crossing back into the central nervous system. Let's put this to the test. Consider this clinical scenario carefully. A patient presents with tinnitus, tachypnea, a pH of 7.41, PaCO2 of 20, and HCO3 of 12. What's the correct pathophysiologic mechanism and next step? Getting this right hinges on identifying those dual mechanisms rather than falling for the trap of assuming simple respiratory compensation. All right, let's exhaustively break down the option matrix here. Choice 1 is incorrect. That severely low bicarbonate indicates we are definitely not dealing with a single respiratory alkalosis. Choice 2 is out. Applying Winter's formula reveals a PaCO2 of 20 is just too low for simple compensation, so that rules out a single AGMA. Choice 3, incorrect. Acetozolamide would actually acidify the blood further by dumping bicarbonate, which would literally be lethal here. Choice 5 is a classic dangerous trap. Intubating this patient and putting them on standard ventilator settings often completely fails to match their massive compensatory minute ventilation. That leads to rapid acidemia and cardiac arrest. So the only correct option is choice 4. You recognize the mixed primary disorder and immediately initiate IV sodium bicarbonate to alkalinize the urine and clear that toxin. Always isolate the clinical variances. In salicylate toxicity, a normal pH is a trap, hiding 2 simultaneous opposing primary acid-base shifts. Bottom line, if you see a normal pH with wildly abnormal CO2 and bicarb levels, you are looking at a mixed disorder. Period. Moving on to Module 2, cellular respiration blockade. Let's differentiate 2 deadly cellular respiration blockades that you'll often see combined in house fire simulations. Notice the distinct divergence here between carbon monoxide and cyanide. Carbon monoxide targets transport. It binds hemoglobin with literally 200 times the affinity of oxygen. This creates carboxyhemoglobin, severely shifting the oxygen dissociation curve to the left.
Cyanide, on the other hand, targets utilization. It arrests the electron transport chain entirely at complex IV. The consequence of that? Massive, unchecked anaerobic glycolysis. Now here is a high-yield trap. The absolute critical marker for carbon monoxide poisoning is a falsely normal pulse oximetry reading. Standard pulse ox devices just cannot distinguish between oxyhemoglobin and carboxyhemoglobin. Plus, the PaO2 on a blood gas will read as entirely normal, simply because the dissolved oxygen in the plasma remains completely unaffected while the actual hemoglobin carrier molecules are hijacked. Conversely, cyanide paralyzes cytochrome C oxidase in the mitochondria. This means tissues literally cannot extract oxygen from the blood. The result? You see characteristically bright red venous blood, because that oxygen is just never offloaded. And you get a massive, rapid lactate spike, as the body instantly reverts to anaerobic metabolism. Let's look at an integrated assessment. A firefighter rescued from a burning building presents with a coma, normal pulse oximetry, and a wildly elevated lactate of 14 millimoles per liter. What is the targeted pharmacologic intervention? This specific presentation demands that you bypass hyperbaric oxygen alone and target the cyanide directly. The competitive matrix forces a really precise choice here. Choice 1, hyperbaric oxygen therapy, treats the CO poisoning, sure, but it does absolutely nothing for the lethal cyanide toxicity that's driving that lactate of 14. Choice 2, methylene blue, is the treatment for methemoglobinemia, not cyanide. Choice 3, flumetazole, is strictly for toxic alcohols like ethylene glycol. And choice 5, sodium bicarbonate, doesn't fix the underlying electron transport chain blockade. That leaves us with the only correct answer. Choice 4, nitrites or hydroxycobalamin. Nitrites induce methemoglobinemia. That oxidized hemoglobin binds with incredibly high affinity to cyanide, acting like a magnet to pull it right off the cytochrome C oxidase and restore cellular respiration. This clinical variance isolates a highly tested distinction. A normal pulse ox points straight to CO, but the addition of profound lactic acidosis in a combustion scenario absolutely guarantees cyanide is also in play. That nuance guides your definitive treatment arm away from just throwing oxygen at them and toward administering specific antidotes. All right, let's hit Module 3, hypoventilation syndromes and reversal hazards. We're going to contrast severe hypoventilation syndromes and isolate a highly tested, lethal pharmacological contraindication. Both opioid and benzodiazepine toxicity depress the central nervous system, driving a primary respiratory acidosis characterized by an elevated PaCO2 and a decreased pH. However, they present with very distinct clinical differentiators on your physical exam. Opioid toxicity gives you those classic pinpoint pupils, meiosis, alongside profound life-threatening respiratory depression. Pure benzodiazepine toxicity, though, usually features normal pupils and only mild respiratory depression, unless they co-ingested alcohol. Consider a clinical vignette where you find an unresponsive patient. The physical exam reveals a respiratory rate of barely 6 per minute and 1 millimeter pupils. That profound bradypnea, combined with meiosis, definitively isolates an opioid toxidrome over benzodiazepines or other CNS depressants. Now, you literally need to engrave this high-yield rule into your memory. Utilizing flumazenil in a patient with chronic benzodiazepine use or an unknown mixed ingestion carries an extreme risk of precipitating intractable, life-threatening seizures. Remember, benzodiazepine withdrawal is deadly. Opioid withdrawal is just miserable. Let's integrate this data into one final assessment. An obtunded patient presents with a respiratory rate of 6, normal pupils, and empty bottles of diazepam and oxycodone lying nearby. What's the immediate management? Now remember, co-ingestions can sometimes mask those classic pinpoint pupils of opioids. This mixed ingestion scenario is a major clinical trap when it comes to reversal agents. Let's break down the choices. Choice 1 and Choice 3 are instantly fatal errors. Giving flumazenil to a patient who just overdosed on diazepam risks throwing them into immediate status epilepticus. Choice 4, administering bicarbonate, is for salicylates or TCAs, not this toxidrome. Choice 5, N-acetylcysteine, is exclusively for acetaminophen hepatotoxicity. This scenario strictly requires you to select Choice 2, administer naloxone only. You absolutely must secure the respiratory drive by reversing the opioid while strictly withholding flumazenil. Your management sequence here has to be incredibly disciplined. You aggressively reverse the opioid-induced respiratory failure with naloxone, completely protecting the airway, all while allowing the benzodiazepines to clear purely through supportive care and time. Never, ever risk that withdrawal seizure. This final clinical variance isolates exactly how identical respiratory acidosis diverge based entirely on pupillary response and context. It dictates a management path that either saves the patient with naloxone or precipitates a fatal seizure with flumazenil. Recognizing these mechanistic divergences is exactly what secures a top-tier score. Learn the traps, master the mechanisms, and you will absolutely dominate these clinical simulations.